Welcome back to the Ninja Nerd Podcast. Today we're talking all about oncologic emergencies. There's a lot of emergencies for us to go over, so we should not waste any time.
No, I think the goal is to try to, for the most part, you'll be able to figure it out, but figure out which type of oncologic emergency it is based upon the HPI, labs, imaging if present, and then how would you kind of go about treating it?
All right, let's do it. So first up, Zach, we have a 42-year-old woman with AML. 9 days post-induction chemo. Presents with fever, fatigue, and mild abdominal tenderness. Her vitals are temp 38.4 Celsius, heart rate is 110, BP is 102/65.
All right. Well, when I think about oncologic emergencies here, when you have a patient who has usually hematologic malignancy like AML, maybe even lymphoma, but usually any kind of hematologic malignancy where they already have alterations in their bone marrow production of white blood cells. So this person probably has some less functional neutrophils. That's going to make it already kind of difficult. So whenever they got chemotherapy and radiation therapy can hit the bone marrow, and it can kind of shut down the bone marrow and put it into like a myelosuppressive state. So it can drop the number of neutrophils that are being produced in this patient. So if they have less functional neutrophils, and then on top of that, they have, let's say in this scenario, chemotherapy that knocks down their normal production, this can put them at high risk of neutropenia. Neutropenia is pretty dangerous because one of the things is you lose the ability to clear pathogens, bacteria. It's one of the first kind of lines of defense for your innate immunity. So now that they have fever, abdominal tenderness, that's the thing. Chemotherapy likes to cause mucositis. It likes to hit the GIT, so it likes to cause colitis. If you cause colitis, now you lose the mucosal barrier. Bacteria, gram-negative rods, boom, right across into the bloodstream. Usually you have neutrophils that will help to kill those bacteria and fight them off, but this patient now has probably neutropenia. Bacteria were able to thrive, cross the GIT. I'm guessing that now this is putting them in a pretty tough scenario that they have a fever, anything greater than 38 degrees Celsius. And the heart rate's a little high, so they have a little bit of a tachycardia, and their BP isn't like technically low, but it's on the lowish end. So I'm kind of wondering if they're starting to develop some signs of sepsis. So that would be my initial concern. The only way I can prove this, though, is I would keep training their temperatures, make sure that it continues to support a fever greater than 38 degrees centigrade. And then on top of that, I get a CBC. CBC with a differential to help to tell me, is there any kind of neutropenia present? Because if I see that there's a low white blood cell count, that's fine. But I want to know the absolute neutrophil count. And I want to see if that's less than usually 500 cells per microliter is the way that we go about that. The other thing is that given this patient has a fever, they have history of chemotherapy and hematologic malignancy, I better make sure that with neutropenic fever, it can really progress quickly. And so I want to get blood cultures. That's the first thing. And then sometimes pneumonia is a common presentation, so I probably get a chest x-ray. So that's what I would start off with first. I would only get additional tests like a urinalysis or urine cultures, wound cultures, CSF, stool cultures, only if they have particular symptoms. Like if they had just complete severe abdominal pain and diarrhea, maybe I'll get a stool study. If they had dysuria, frequency, urgency, white blood cell cast, leukocyte esterase, nitrites, maybe I'll get a urinalysis with a urine culture. If they had a surgical site that looks really wounded, not wounded, it looks indurated, red, it's sore, it's painful, I maybe do a wound culture. So I would do those things based upon localizing signs and symptoms. But right off the get-go, CBC, blood cultures, probably chest x-ray.
Okay, well, let me go over those results for you. The CBC shows an absolute neutrophil count of 120, so very low.
Yeah, bad.
Chest x-ray is unremarkable.
Okay.
And our blood cultures are still pending. So what's next?
All right, so we definitely have neutropenic fever. When we have the diagnosis of neutropenic fever, which is the absolute neutrophil count less than 500, and then a temp of greater than 38 degrees centigrade, we have neutropenic fever. With this, you don't play around. The blood cultures, as long as you got them prior, because I've made this mistake when I started in the ICU, where I'd have a patient come in, they're septic, they definitely seem septic, they're hypotensive, multiple pressors, and one of the common mistakes that happens, and this is unfortunate, is that the ER or whoever the person is who's starting the history and physical exam on the patient, they put in orders, they commonly, they look septic. What do? They order empiric antibiotics. And they start them on empiric antibiotics, but they didn't get the cultures taken. You might be okay if you got a dose or even maybe 2 of antibiotics, but if you're really playing with fire and taking a chance at not identifying the true type of bacteria that you need. So it's always best, get the blood cultures as soon as you possibly can, and after those blood cultures are drawn, just nuke them with the bug juice, which is the antibiotics. So that's probably what I'm going to start them on. Given the fact that I have a patient with neutropenic fever, I'm going to treat them with gram-negative rod coverage and gram-positive coverage. So I like vancomycin to cover my scary one, MRSA. And I prefer piperacillin and tazobactam, which is also known as Zosyn or cefepime, one of those two. And that's going to cover any kind of my gram-negative rods, but the scary one is Pseudomonas. So that's what I would do first. I wait for my blood cultures to come back, and then I would kind of change my antibiotics based upon what that culture comes back with.
Now, depending on the patient and complications, are there any we should keep in mind while we're still treating the patient? And even if the blood culture still hasn't come back yet, what would you do in that scenario?
Yeah, so I think we're going to keep them on antibiotics, and we'll obviously trend their CBC, keep an eye on that, keep an eye on their temperatures. Make sure that we're not losing any other source. Again, if we had a normal chest x-ray, blood cultures are pending, you probably had it coming from, my guess is the colitis. So I'm guessing that's probably where the source is. But if I had other concerns about another area, I may have to do some further imaging. But for me, it's about treating the potential of them progressing to sepsis or septic shock. So for them, if they end up having a neutropenia, a fever, they already have tachycardia. If they start getting hypotensive, I'm worried about septic shock. They already have a lot of the credibility here to say that they're septic. But septic shock would be the scary thing that I would watch out for. So I would obviously do like a 30 cc per kilo bolus of IV fluids, particularly lactated ringers. And then from there, I would also put them on any kind of like vasopressors to support their mean arterial pressure during that time frame. So that's what I'm going to do right there. And then I'm definitely going to put an ICU consult, have them closely monitor for those vitals.
This patient's meeting SIRS criteria, right?
Yeah, definitely meeting SIRS criteria.
So you're concerned then about septic shock?
Yeah, already I'm pretty concerned. There's obviously a lot of different kind of like scores and different kinds of like ways that we can determine if a patient's septic. I think there's the SOFA score, there's the SIRS, there's so many different things, but I think this patient right here, just based upon the neutropenia, based upon the fever, based upon the tachycardia, I'm going to go, and then obviously we're waiting on blood cultures, but this patient definitely fits the definition of sepsis for me, and so my concern is them next progressing to shock. That would be the scary thing.
And then being that you said you probably would cover them with something like Bactrim, that would really give you the best possible chance.
I would do something like vancomycin and piperacillin and tazobactam. Those are going to be the better ones to start off with.
So that's not quite good enough then.
No, Bactrim is good for MRSA, but usually for these ones, Bactrim it's oral. You could definitely do that. I think it's always better to start with vancomycin. It's usually better for hospital-acquired MRSA as compared to more community-acquired MRSA.
Okay, so definitely IV.
Yeah.
You're going with the big boys.
Yeah, IV vancomycin, IV cefepime, or Zosyn, which is piperacillin and tazobactam. Those would probably be the ones I go with, and then based upon the results of the culture, I'd narrow my antibiotics down.
Okay, perfect. And then I'm guessing, obviously, if they continue to deteriorate, it's probably let's get them transferred to ICU.
Exactly. I think that this patient is going to get an ICU bed no matter what.
Oh, okay.
Yeah.
Gotcha.
Given the kind of like we use things like Mu scores, but right here, this definitely is a person that I would want to keep a close eye on.
Yeah, you're not messing around with this one.
Yeah, I'd say that they're probably going to go to the ICU just to be monitored, even if it's for a 24-hour period. I might send them, talk to my ICU colleagues and say, hey, can you watch out? I just have a concern that they're going to kind of deteriorate a little bit because that's usually what can happen with these.
Okay. All right. Well, that was case one. Let's move on.
All right.
We have an 18-year-old male with newly diagnosed Burkitt lymphoma. One day after chemo, he has flank pain, vomiting, and weakness. What is that telling you right there, Zach?
I mean, Burkitt's lymphoma is a pretty hefty tumor burden. This one's in a pretty aggressive non-Hodgkin's. So they can have a pretty nasty tumor burden. And if you get chemo and all of a sudden you have flank pain, something going on with the kidneys, could they have, I don't know. I mean, it's unlikely for them. They could get stones. It's possible, but I don't think that's the likely thing. Vomiting and weakness. This is something I'd be concerned about with potentially tumor lysis syndrome. I don't have a strong enough history to kind of tell me that, but I'd say what I'd have to really kind of look for here is let me get a CMP. I think the CMP will be good because it'll give me the renal function, because tumor lysis syndrome definitely likes to hit the kidneys, especially with the uric acid. It'll also tell me their potassium. It'll give me kind of their total calcium. I'd probably add on a phos, I'd add on a uric acid, and then depending upon the results of the CMP, I may get an EKG if their potassium is pretty high, just to watch out for any EKG changes. So that's what I would get to start off with. Is I would do a CMP, they give me my calcium, they'll give me my creatinine, and I think that would be and then the potassium, and then from there I add on a phos, a uric acid, and then from there EKG based upon potentially the the results of the potassium coming back.
Well, let's say we go forward with the EKG.
Okay.
Let me give you all of them.
All right.
So the labs show a potassium level of 6.4.
All right, elevated.
Phosphorus 7.0.
Elevated. All right.
Calcium 7.2.
A little low.
Uric acid 11.8.
Oh, shit, that's high.
Creatinine 2.1, and their baseline was 1.
Okay.
And then we see on the ECG peaked T waves.
Yeah, so this is tumor lysis syndrome.
How do you know that this is tumor lysis syndrome?
Yeah, because with tumor lysis syndrome, you can, this is what was, it was one of the textbooks. I think it's like first aid. It's the mnemonic puke.
Okay.
So, and you can remember puke for P-U-K is all uppercase. And then the E, in this case, it's lowercase. So you have P is going to be phosphorus, that's elevated.
Yep.
U is uric acid, that's going to be elevated. Potassium is going to be elevated. The only one that's going to be low is calcium. So they are using the mnemonic puke calcium. So P-U-K-E, phosphorus, uric acid, potassium is elevated, and then calcium, which actually that's the part that's in lowercase, calcium is low.
Gotcha.
So that's what I would see here is I have a high phosphorus, I have a high uric acid, I have a high potassium, and I have a low calcium. Now the creatinine being elevated is probably evidence of them having an acute kidney injury, which is unfortunate, but that's what happens with elevated uric acid. And then the peak T waves is likely going to be due to the elevated potassium.
Okay.
So that's something I'm already seeing. This makes this patient a little bit more high risk, pretty scary. They definitely have active or acute tumor lysis syndrome, so we got to be pretty aggressive with these patients.
So you're worried about acute renal failure. How are you going to treat this?
So the first thing you want to do is with these patients, and you got to play this by ear. I'm never a fan, and if you guys have listened to me in these talks, I don't hit people with just massive amounts of fluids just because that's what natural dogma and teaching tells us to do. You have to look at the patient's volume status. If they look like they're volume depleted, if they have some evidence of volume depletion, give them some fluids. In this case, I would definitely give them some fluids. That's going to help a little bit to maintain euvolemia, but it may help a little bit with kind of like flushing out some of those kinds of molecules. I just don't think that concept is as widely understood and accepted as we think it is. But IV fluids is going to be helpful because you are busting open cells. You're releasing out a lot of the intracellular content. So they definitely can get volume depleted. Also, when you have an acute kidney injury, your kidney becomes very injured, it becomes susceptible, and so it depends upon good volume and perfusion. So having normal blood volume helps to prevent kidneys from getting further injured. So that's why I like to aim for euvolemia. The next thing is people would say, okay, which one do you pick? Allopurinol or rasburicase in this scenario? And we've talked about this. I actually think we talked about it in the acute leukemias lecture. But this right here with tumor lysis syndrome, you always go rasburicase. Rasburicase actually helps to convert uric acid into it's kind of like a non-toxic breakdown of uric acid called allantoin, and that can go to the kidney and get excreted out. And so that's going to lower that uric acid because what keeps happening is the uric acid crystals form. So that's the thought is when you give fluids, you're helping to prevent uric acid nephropathy, so the precipitation of those crystals. That's why you give them some fluids to kind of prevent that precipitation. But my goal is to give them rasburicase because that's going to attack these cells and say, okay, hey, we're generating a lot of uric acid because these cells are popping open. All I can do is help to convert that toxic uric acid into a less nephrotoxic chemical. Using allopurinol, that doesn't convert uric acid into less toxic forms. All it does is it decreases the production of uric acid. But if you're already busting open cells and releasing uric acid, there's not much else that you can do with that. So that's not what I would go for first. I would do pretty good fluid resuscitation, aim for euvolemia, maybe a small maintenance fluid kind of like infusion, and then I give them rasburicase. And I would keep a very, very close eye on their potassium because the potassium is the one that can actually get them, especially having peak T waves. I'd probably start to go the route of treating these patients. So you guys remember when we treat hypercalcemia? So usually initially, especially when we have EKG changes, is always calcium gluconate. So that's going to stabilize the cardiac membranes. And then after that, we can do things to shift the potassium. So I would do things like insulin. I may even give them a little bit of glucose if their glucose was kind of on the lower or normal end. And then I would also do like an albuterol treatment. And then from there, we have to try to excrete it. So that's when I would either reach for Lasix, which we're trying to resuscitate these patients with fluids. Probably wouldn't give them that. I'd probably go to something like Hyperleukocytosis if I had to. So that's the way that I would go to kind of treat the hyperkalemia and keep a very, very close eye on that. And if it got really, really bad where the renal failure really progressed, we might have to reach for dialysis in this patient. So
We had a few red flags on the CMP. How often are you monitoring those levels?
for these, probably every 6. I'd probably go pretty quick. Like
6 hours, okay.
Yeah, I think like if you go like a lot of the times when you have these kinds of changes and you're trying to, especially with something, for example, I always think like, for example, like when I was in the neuro ICU, we would trend sodiums because you're treating a patient, right? And so, for example, if you're using a sodium target, which is not the best guideline for a lot of treatment things in neurocritical care, but you have a patient who has cerebral edema or an ICP crisis, you give them a hypertonic saline, bolus or infusion, you're trying to see, hey, what's that thing doing for me? So what happened to their sodium? Okay, it was 140. We've been giving them hypertonic saline at 50 cc's per hour for the past 4 hours. All right, well, once we get a 6-hour time frame, we should actually check and see what happened to the sodium. It's the same thing here. If I'm treating these patients aggressively, giving them things like rasburicase, giving them things like fluids, and they have an active acute kidney injury that's really bad, I'm going to keep a close eye on their urine output. I'm going to keep a close eye on all of these types of electrolytes in their EKG, and then make sure that if I'm treating their potassium, if I'm treating their volume status, if I'm actually keeping a close eye on their uric acid and their kidney function, I should be training that more frequently, every 6 hours. If you need to, you can go to 8, but I'd say every 6 hours. Don't do it twice a day or once a day. You definitely need to do more frequently.
Case 3.
All right.
We have a 67-year-old man with known prostate cancer, presents with new onset lower back pain and bilateral leg weakness. He has urinary retention and decreased rectal tone on exam.
So that definitely, I mean, you know this too. Sounds like spinal cord compression,
yeah.
right? Maybe of some sort. Could it be like a cauda equina kind of thing?
Yeah,
possibly?
Decreased rectal tone is never normal. That's not good.
No.
That's bad.
Yeah, they always talk about in school, like, you lose your anal wink reflex.
Yeah.
Yeah. But I think for this one right here, it's definitely concerning, especially prostate cancer. Loves bone. Loves it.
Loves it.
Yeah. That's a Sebastian Maniscalco reference if you don't know. But anyway, prostate cancer, one of the nasty ones about this is it likes to cause, instead of osteolytic lesions, it causes osteoblastic lesions. Yeah. And so definitely loves the vertebrae, can actually cause like vertebral body metastasis, and they can kind of erode, and they can cause an epidural mass to kind of pop in there. And that can start pressing on the spinal cord. So if you have that, you obviously get the low back pain if it's in that vicinity near the prostate. Bilateral leg weakness means it's probably encroaching in on those lateral white columns where the corticospinal tracts are running through. And then urinary retention, decreased rectal tone, they're kind of losing that, probably the autonomic, but also just the descending pathways from the autonomic systems from upper levels down to those portions of the sacral cord where it goes to the rectum and where it goes to the bladder. So this definitely sounds like some spinal cord compression. Right away with these ones, if you have any inclination, you start dexamethasone right away.
Yeah.
And then, you can't, I can't like call a surgeon and be like, hey, I think this guy's got spinal cord compression. No, I got to confirm it too. So I would say I'd get an MRI. I'd get an MRI of the spine, get a close look there. And if I have any inclination there, I'd probably start them on dexamethasone IV, probably like 10 milligrams right off the bat. Usually you might want to wait for the spine MRI to come back. If I see lots of vasogenic edema, I'd probably give the dexamethasone right after that.
All right, I have the MRI results for you. It confirms thoracic vertebral metastasis with spinal cord compression, just as you suspected. So what do you do next?
Well, I mean, definitely was a little higher than I thought. But hey, that's definitely that's sucky in this scenario. But yeah, I'd say, all right, steroids first. I'd give him pretty good bolus of dexamethasone, probably 10 milligrams IV. Put him on a scheduled dosing after that. I'd probably consult 2 people. One is I'd reach out to neurosurgery, see if there's any kind of possible like debulking surgery that they could do to remove the tumor, and any kind of like stabilization. And I'd also reach out to rad-onc, and I'd see if there's anything that they can do radiation therapy-wise that could help to preserve neurological function. But the steroids are going to be the first thing up front to kind of reduce the vasogenic edema, help to kind of preserve what you have, and kind of just worsen that further venous congestion, arterial compromise. And then from there, I got to get neurosurgery or rad-onc on board. But probably neurosurgery acutely, rad-onc probably not as much in that scenario.
I'm sure you can probably imagine, but what complications are you most concerned about with this patient?
I mean, if you continue to let venous congestion occur, more swelling, more compression of arteries, you can end up with ischemia, and eventually you can have like complete loss of neurological function. So paralysis would be the big concern, and along with that, loss of permanently, potentially, bladder and bowels. So that would be the scary thing in this potential scenario.
Okay. All right. Well, let's move on to case 4. We have a 45-year-old man with suspected AML presents with dyspnea, blurry vision, and confusion.
All right.
Chest x-ray shows bilateral infiltrates. So what's going on here?
This is the one, like, if you watch our videos on acute leukemia, leukostasis is pretty common in AML. And so that's what I'm thinking about with this one, because with AML, if you hear dyspnea, blurry vision, and confusion, that right there. If you guys didn't see that, you guys got to fucking rewind it back. I bumped this thing in his eyes.
Hey, I got to make sure that, if you're using headphones,
all
of a sudden,
gone.
Pop.
Yeah. You got a hole in the tympanic membrane now.
I'm just looking out.
Yeah. Sorry about that, but...
What were you saying?
Yeah. So with AML, when I hear dyspnea, lungs, blurry vision, I think about the retina, confusion, brain. Leukostasis is a condition in which AML, they have hyperleukocytosis, so white cells that are greater than like 100,000. Enough of those blasts, the myeloblasts, they're too big, they're not very flexible, and they get stuck in microvessels. And so they can cause microvascular occlusion, especially to the brain, where they can cause things like headaches, confusion, neurological deficits. They can clog up the retinal veins, where they can cause visual changes due to like papilledema. They can literally cause like cotton wool, or the actual small like microhemorrhages as well. And then the last thing is dyspnea. They can clog off the pulmonary system, and so they can have things like, similar to like a pulmonary embolism. So they may have dyspnea, they may have tachypnea, they may have hypoxic respiratory distress. Sometimes they can even get bilateral infiltrates and stuff. So that's probably what I'm thinking, but I got to get the CBC to see if that actually is even the case, get the peripheral smear, see if they have tons of these myeloblasts. And that's probably what I would start off with first.
Yeah, well, you're spot on.
Oh, am I?
Our white count is 140,000.
Oh my gosh.
Smear shows our rods, and guess how many of those white cells are blasts?
How many?
75%.
That's a lot, dude. Yeah,
that's a lot.
That's a pretty significant left shift there. So that right there tells me it's definitely leukostasis. I mean, with this kind of scenario here, I actually am kind of scared for this patient. So they have significant symptoms, especially neurological and pulmonary. When you have things like that, especially if it was like focal deficits too, I would call and find a facility that does something called leukophoresis. So leukophoresis is a process by which you actually remove these blasts from the circulation so that you're trying to not continue to clog up those vessels. Mm-hmm. So that's what I would do emergently. I would try to find any hospital nearby that could transport this patient that would have that facility, the abilities to do that process. But then in the meantime, I'm going to put them on hydroxyurea because that helps. It's not as quick, but it does have more of a longer lasting effect at kind of causing what's called cytoreduction, reducing the number of like these white blood cells that are being produced by the bone marrow. So that's what I would go for in this particular scenario for sure skis.
For sure skis. Good. Yeah. What's the pucker factor here? What's the thing that gets you most concerned?
I'd say like hypoxic respiratory failure. That would probably be a scary one because, again, unless you get them on leukophoresis, there's probably not much else that you're going to do. And then stroke, I think, if you have enough microvascular occlusion, they could have permanent neurological deficits.
So when these patients start to go downhill, they go downhill quickly.
Oh yeah, it's pretty scary. Yeah, I've never seen it. I thought once we had a patient who might have had it. But no, they actually had like a cardioembolic stroke from AFib. But wow. They also had a condition where they didn't have an acute leukemia. They had CML, and we thought that they had like a blast crisis. And they came in and they had neurological deficits. We got an MRI. We saw a bunch of like small areas of strokes. Their white count was around like, I'm not kidding, I think it was close to like 170,000 or something like that. Yeah. So we thought, oh man, this could be a blast crisis that put them in leukostasis, but it wasn't. So interesting in these kinds of scenarios.
Wow, that's tough.
Yeah. That's tough. This guy. That's his filler word. You know how mine's actually? His is that's tough.
Yeah, I did that on purpose. It took him a little while to catch on.
Yeah, I know. I'm not that smart.
All right. Well, we're on case 5, Zach.
All right.
We have a 50-year-old woman with metastatic breast cancer presents to the clinic with fatigue, hypotension, and dyspnea.
Okay.
Exam reveals JVD, distant heart sounds, and pulsus paradoxus.
Yeah, dude, that's tamponade, baby.
This is not good.
No.
Remind me again what pulsus paradoxus is.
So you'll always love this one, don't you?
I'm just curious.
So it's whenever you have, in these kinds of scenarios, you have a pretty decent drop in your systolic blood pressure during inspiration. And so it's kind of paradoxical, thus the name. So usually during inspiration, you should take a deep breath in. Your thoracic cavity volume increases, the pressure decreases, and blood from your vena cava superior should suck down into the right heart, get more blood into that right heart. You should also get that over to the left heart, so you should have a good stroke volume, cardiac output, and the blood pressure should go up. But in these patients who have cardiac tamponade, or like a really bad tension pneumo, it's squeezing on the heart and it's reducing the filling, especially during inspiration. And so they get a drop in their venous return.
Okay.
They don't fill that ventricle during inspiration. And then whenever they push that blood out, they get less volume or cardiac output getting pushed out into those vessels. And so that's why their blood pressure drops during that inspiration.
So this is a pretty dead giveaway for you.
Yeah, I mean, pulsus paradoxus can occur in other conditions, but breast cancer, lung cancer, lymphoma loves the pericardium.
Okay.
JVD, there's not many things that causes, well, actually that's not true. A lot of things can cause JVD.
Sure, but with other findings here, it starts to say, wait a minute, this is all pointing to cardiac tamponade.
The distant heart sounds, the JVD, the pulsus paradoxus, the hypotension. And funny enough, you know what the actually most common symptom I've ever seen when I had a cardiac tamponade patient? Dyspnea.
Oh, yeah?
Yeah, I had a patient who had renal failure, really bad renal failure. And so we were worried that they were having like uremia. And they they had pericarditis from their uremia. And then it had been accumulating, and they were complaining of worsening dyspnea. And then finally, they ended up having cardiac tamponade. It was pretty nasty.
That's harder to suss out, though. I mean, just some shortness of breath. That could be a million things.
Yeah, I mean, they didn't have many other things that were going on. Obviously, we were doing things like chest X-ray.
Right.
We decided to throw the point-of-care ultrasound right over the chest, and we were like, holy crap. It was one of those where cardiac tamponade is kind of scary. Just because you have a large, pericardial effusion doesn't mean that you have tamponade. You actually have to see that compression or collapsing of the right atrium and the right ventricle during diastole. But this patient had it. They also had a pretty good amount of like thickening of the pericardium, so we could see that they had uremic pericarditis, and it had been accumulating, and unfortunately they had cardiac tamponade.
So for our patient here, we're definitely doing an echo.
Yeah, I'd get an echo. Yeah, do a stat one if you can. Obviously, point of care is the best way to go if you have some skills in that area. But getting your subxiphoid, your parasternal long axis, short axis views, taking a good look at that. And the key thing is just really looking to see, does the right atrium, the right ventricle collapse during diastole, and do they have less velocity of blood flow coming into the ventricles during that diastole?
All right. Well, for the purposes of this exercise, for this case, let's just say that we have a large pericardial effusion. We have right ventricular diastolic collapse. What do you do?
I mean, so right then you say and a lot of cardiologists will, fight you tooth and nail on these kinds of things, but
you got to drain that thing.
Yeah, that's the best way. A lot of them, cardiologists and, people who work in the ICU, a lot of them have, the ability and a lot of the tools and stuff at their disposal to say, well, the best way to determine if this is causing their hemodynamic collapse is to stick a needle into the pericardial cavity, pull off some volume, and see, does that improve their hemodynamics? And so that's what I would say. I've always been a believer. There's a guy on the Internet Book of Critical Care podcast, Josh Farkas. He's amazing, super smart guy. Go check out that podcast if you guys are interested in ICU level care. But he always says that one of the best ways of really diagnosing this and also providing therapy for it is doing a pericardiocentesis. There's no better way of determining if a patient is in cardiac tamponade other than tapping it in, pulling off that volume and saying, oh, they improved hemodynamically. There's no other logic that can explain this likely. So I think that'd be the way to go. If it kept coming back, like they recurrent effusions, and this patient likely has those risks, pericardial window would probably be the long-term thing that I would say.
Okay. How about if this is left untreated?
Oh, death.
Very bad things.
Yeah, I had one. It was actually, I think I've only had 2 cardiac tamponade patients, but the one we found, and they just went into PEA arrest. So oftentimes these patients, if you don't treat them properly, they develop severe hypotension, they can develop obstructive shock, and then they can have pretty much no cardiac output to the point where you're not supplying their coronaries. They end up going into VTAC, VFib, asystole, PEA, things like that. So that's the scary thing that you can see with these.
Similar to leukostasis, where you just go downhill quickly.
Yeah, absolutely. Absolutely.
Right. Let's keep moving here. Case 6.
All right.
Here's a classic board-style case.
All right.
We have a 68-year-old man with known squamous cell carcinoma of the lung.
Oh.
He's like, I already know it.
Yeah.
He presents with confusion, generalized weakness, poor appetite, constipation, and polyuria. On exam, he's mildly hypotensive. He has dry mucous membranes and sluggish reflexes. Well, come on, spill it.
Seems like hypercalcemia of malignancy. So since we're talking about oncologic emergencies, when you hear squamous cell and then you hear like confused, so stones, bones, groans, thrones, psychiatric overtones, right? So I think with a lot of this, we see some concerning features of hypercalcemia malignancy, especially with squamous cell carcinoma. So I never want to assume, but I'd probably start off with just doing a basic like CMP. If I get a total calcium, just because if calcium is like elevated doesn't mean that it's always the case. It's more likely. But I'd probably check an ionized calcium. I always like to do that. I think it's a little bit more accurate, or correct it for the albumin. If that's elevated, I start with PTH. Then I would consider, okay, if the PTH is low, I would rule out other causes. So the malignancy causes. I would get a PTH-RP. I would get the vitamin D levels, so the calcitriol. I would get, both calcidiol, calcitriol. And I would even consider getting an ALK-Phos level, because that can tell me about heavy bone turnover, which we can see in like lytic lesions, or kind of like, usually due to cancers that have kind of incorporated itself into the bone. Breast cancers is a big one. Multiple myeloma is a nasty one as well. So that's probably what I would start with first, is to get those things and see what comes back with that.
So our total calcium is 15.7. Albumin is 3.6, ionized calcium 1.7, creatinine 2.1, with their baseline being 1.0. Their ECG, we note a shortened QT interval. PTH is low, PTH-RP is elevated, and then our vitamin D, normal, ALP, normal.
All right, so based on this, I'd say, okay, we have hypercalcemia. We confirm that you can correct it with the calcium and the albumin. Ionized calcium is an easy one for me, so I don't have to do any math though. So 1.7, that's definitely elevated. Creatinine, they have an acute kidney injury of sorts, probably in the setting of hypercalcemia is due to nephrogenic DI, so they probably lost way too much volume. So they're probably a little dehydrated. Shortened QT interval, that's usually kind of consistent. It's inversely proportional relationship with calcium. So the QT interval, if it's shortened, it means that the calcium is high. If the QT interval is prolonged, it means that the calcium is usually low. So that could be likely explaining that. PTH is low tells me that it's PTH independent, so it's not hyperparathyroidism. PTH-RP is elevated though. That's squamous cell.
Okay.
So usually in squamous cell carcinoma, that's elevated PTH-RP, and that could be head, neck, lung. Lung's probably the most common one though. 25-hydroxy and 1,25-hydroxy vitamin D. We see this particularly in like lymphoma, but that's normal. So that's unlikely there. And ALK-Phos is normal, so there's not a lot of bone turnover that makes me think that I would need to do like a skeletal survey to look to see if there's any lytic lesions. So that's kind of what it tells me in this potential scenario of what I have going on here, is that it's likely squamous cell carcinoma.
Okay. Well, how do we manage him?
So first thing is treat them acutely with volume resuscitation. So these are the few patients where I think that they actually do need a good amount of fluid. Probably one of the few patients that I'm going to hit with a good amount of fluid.
I was going to say, you hate giving fluid.
Yeah.
God forbid you want to give fluid.
Yeah, I think this is a one I'd probably give a good amount of fluid, probably start off 1-2 liters, see how they do, and then aim for euvolemia there. I don't know if it helps as much with the calciuresis, but I think it's, at least aiming for euvolemia is the goal. From there, calcitonin is actually, I think, what we would say is the better fit for short-term acute needs, because it's really going to help to kind of shut down the osteoclasts and stop them from helping to turn over the bone. So that's going to reduce a lot of the bone resorption, which is what PTH-RP is doing in this scenario. And then after I got that, calcitonin works quickly, so it's rapid onset, but I need something that's going to bridge me long-term and give me more control. So that's when I reach for 2 agents, 1 to 2, bisphosphonates, all your dronates, alendronate, xalendronate, palmidronate, all those good ones. And then if they have pretty bad kidneys, you can consider denosumab. But I think that this patient's okay. I would still try bisphosphonates, see how their kidney function does. And if it really starts to veer off, I have options of denosumab or doing dialysis if it's really bad. But I would only do loop diuretics, because they say throw a loop diuretic in there. If I did fluids and a loop diuretic, the nurses would massacre me. They would be like, make up your mind. Which one do you want? You want them to pee, or do you want them to have the fluid resuscitation? Because it doesn't make any sense. But this does happen sometimes. It used to be more believed that you give them fluid to pump them up and then give them loop diuretics to induce calciuresis, because that actually does do calciuresis. But we prefer not to give diuretics unless they're truly volume overloaded. So fluids, calcitonin, bisphosphonates, or denosumab. If this was lymphoma, I would add on a dose or a couple doses of steroids too. But that's kind of how I would do this one in treating these patients.
So our patient has an AKI. All right, the creatinine was bumped.
Yeah.
ECG, we noted shortened QT intervals.
Yeah.
So these are some concerning complications. How are you going to manage those?
The AKI is the big one, so that's going to get better with volume. So if you give them some volume, they'll improve with that one. Nephrogenic DI improves as you start to so the likely reason for their dehydration, which caused their AKI, is nephrogenic DI. So hypercalcemia actually tends to block ADH at the collecting duct, and so if you improve their calcium, then you should have less blockage of ADH at that collecting duct, and you'll have less of this inhibition of water reabsorption. So that'll also fix a lot of the volume status and also prevent the nephrogenic DI.
And you're not worried about the shortened QT?
No, probably not. I'd be more worried if it was long.
Okay.
Yeah, if I had a long QT, that'd probably make me poo my pants or crap my Huggies, because that one I get scared about, torsades, especially if you have hypocalcemia and hypokalemia. Those are the ones that combine two. I get a little nervous for torsades.
With calcium correction, this just resolve?
It should. Yeah, as you start to improve that one, you'll be okay. But shortened QT, not something I get super concerned about. Probably a little bit more concerned about the long QT though.
All right. Well, there we go. That was case 6.
All right.
Let's move on to case 7.
All right.
This one, we have a 59-year-old man with chronic cough and new facial swelling, SVC syndrome.
Done. All right. Hey, guys, it's been good. I hope you enjoyed the podcast.
I know that one because you've talked about it a million times now.
Yeah.
I just hear facial swelling.
And then you see the pictures that we throw up all the time, and you're just like, I'll never forget it now.
They're scary.
Yeah.
Yeah. I'm sorry, I just a spoiler alert there, but
no, it's good. It's good.
That's an easy one.
You just ruined it for everybody.
No, you see this picture come up, you know it immediately.
Yeah, it's true.
The exam does show distended neck veins and facial plethora.
Yeah, I mean, that's a pretty common term. So whenever they use that stuff, yeah, you definitely should think about it. But
well, what do you do?
I mean, chest X-ray you can always start with people who come in with, a chronic cough and stuff like that. But I mean, if you're really looking for, like you said, SVC syndrome, I'd probably do a CT venography or a contrast enhanced CT scan of the chest, where I'm looking at the venous blood moving into the along its course from the IJ brachiocephalic, or in this case subclavian, moving its way down through the brachiocephalic superior vena cava and looking at it going into the right heart. So if I start seeing that there's a restricted area where there's kind of a small luminal diameter, that would tell me if there's less blood going there. Because SVC syndrome is not always just due to tumors. Believe it or not, I used to see it all the time. It's especially with catheters. So in the ICU, you're constantly putting in central lines.
Yeah.
And so, IJs is a common one. Subclavian's a common one. In the ICU I worked at, we did a lot of subclavian lines. There's lower risk of thrombosis. But IJ, there's just a slightly higher one. But we would put in these lines, and then when these lines come in and they sit in the superior vena cava, it's an opportunity for clots to form.
Yeah.
So you can definitely get thrombi that form there along the catheter, and then sometimes right onto that vein. So I used to see a lot of SVC syndromes particularly, and they were very mild, very, very mild.
Yeah.
But you could see them in pretty significant occlusive clots. And these kinds of scenarios, we're talking about tumors though. All right, we're not talking about clots.
Yeah, we're talking about tumors.
Yeah, we're talking about tumors. It's not a game.
No,
not a game.
We're talking about tumors.
We're talking about tumors. Yeah. So in patients who have lung cancer or lymphoma, anything that's near that area, it's near that central portion. You have your hilar lymph nodes; those things get big. Boom.
Yeah.
Or you have your central lung portion near the mediastinum. That one gets big. Boom. Compresses on the superior vena cava. So lung cancer. Maybe if you have a pretty good thymic mass, and I would say the other one would probably be any kind of really nasty lymphoma. Usually non-Hodgkin's lymphoma would be another one. Lung cancer, sometimes teratomas and things like that, but definitely lymphoma and lung cancer. Those are the big ones that I get scared about compressing on that area. So I would probably start off, look to see if I can see SVC compression. Look to see if I see less blood moving through it, and look to see, do I have a source? That's why I like the CT scan, because you're going to be able to see if I have hilar lymphadenopathy, if I'm going to be able to see if I have lung cancer, a big old mass compressing on
Well, let's get to the money shot here. We got our contrast-enhanced CT.
Okay.
It shows a large right mediastinal mass, and that mediastinal mass is compressing on the superior vena cava.
Yeah, so you got SVC syndrome. I mean, from here, I think if, I don't think they have, no, I don't think that they're emergent. So
maybe urgent.
Yeah, exactly. I call it an urgency.
Okay.
So get to it, call.
Get on it,
I'd get the oncology, probably like your radiation oncology team,
Yep.
maybe the hem-onc team on board, and talk about like, chemoradiation, something to kind of shrink the tumor size so that you're not compressing on this SVC as much. Okay. If they came in and they were having like stridor, difficulty breathing, they were having hypoxia, then I would be concerned, okay, are they having enough backflow from the IJ that it's kind of squeezing? What happens is sometimes you get blood that backflows into the vessels around the larynx and the trachea and things like that, sometimes even into the lungs, but mainly the larynx, and it can cause edema of the larynx. And so they get stridor, they get dyspnea, they have significant difficulty breathing. And so
it's very scary.
And those, I'd probably say, okay, that's an emergency. And another one, and this is why, subclavian, central lines are the lines of champions, but obviously you don't want to drop a lung, but the big thing here is when you have neurological catastrophes where brains are already a little bit injured, they're swollen, you want them to not have anything else that increases their ICP. Yeah. So when you put in a central line in the subclavian vein, you kind of allow the jugular vein to have proper drainage. Nothing is impeding it. So imagine you have a catheter, or imagine you have a tumor that's compressing on the SVC, and it's causing blood to backflow into the IJ. Well, there's veins called the cerebral veins, the superior sagittal sinus, inferior sagittal sinus, the transverse sinus, the sigmoid sinus, all of those, they come down and they eventually drain into the internal jugular vein. Mm-hmm. So if you have a compression of the SVC, it's already causing backflow from the internal jugular vein. It's going to be harder for blood to drain out of the head. Yeah. And that's going to increase their intracranial pressure. And so I think that you would see that more so in patients who have neurological injury or something that's already with a little bit of an increased ICP. You do that, you increase it even more. And so that puts them at high risk.
So very concerning, airway obstruction and then an increased ICP.
Yeah, if that happens, then I'd say you should call like your vascular team to see if they can go in and stent the vessel open. So that'd be the only time that I would say it'd be worthy to kind of push to do something truly intravascular to keep that vessel patent so that blood can actually restore blood flow back down to the right atrium, right ventricle.
All right. Well, hey, we just covered 7 high-yield oncologic emergencies, and I would say we did it pretty efficiently, pretty quickly.
Yeah, that was pretty good, man. I think that was awesome, and I think when you think about oncologic emergencies, there's a lot of them, and it may seem like it's hard to be able to wrap your mind around them, and I get that. I think a lot of the times with these, you have to try and think about what's the most classic clinical presentation. Mm-hmm. And I think based upon that, the big thing I want you to know is think classical clinical presentation, but also think about what kind of conditions is this associated with. That may start to spark your interest and understanding of the concept. The pathophys will help you to understand the clinical kind of like manifestations per se, but I think it's important to know when we have a suspicion of what this is, how do I diagnose it? And then the most important thing is, since they are emergencies, what is the first line treatment? What do I do right away when I have this diagnosis? So I had a good time talking to you guys about oncologic emergencies. I hope you had a good time listening. I hope you learned a lot. I hope you had fun. I hope that while you're cooking dinner, doing dishes, driving, working out, whatever it is that you may be doing in this moment while listening to us, I hope that you enjoyed this, and I really thank you guys so much for being so awesome, so supportive, and I wish you guys the absolute best of luck. I love you. I thank you guys, and as always, until next time.